Welcome to AETCM, the emergency medicine channel. So all are aware, so we started the endocrine emergency series. So in this last part, we see in the diabetic emergency. So as a part of diabetic emergency, we discussed hypoglycemia. So in this second part in the diabetic emergency, today we'll see the diabetic ketoacidosis. So this is what my outline of presentation. So unlike other presentation, in this DKA I am getting you through the some one scenario. So that with that one scenario we'll see here. So by that scenario we'll discuss like how we have to prepare for the pre-hospital, what are the assessment point we will get, because pre-hospital is a, it's a thing, it will be like a limit, resource limited things, right? So in that point, how we have to assess in pre-hospital, how we can provisionally diagnose the diabetic ketoacidosis, what are the management strategies we have for DKA in pre-hospital, and then how we are diagnosing and managing in the in-hospital. So both sides we are going to cover by seeing the one scenario. Okay, before getting into the DKA and then that scenario, we'll see. So in commonly in diabetic emergency, you have a both entity like hypo and then hyper. Means in diabetic emergency, you will get a hypoglycemia and then hyperglycemia. In hyperglycemia, again we have a two subdivision, that is your DKA and then HHS, diabetic ketoacidosis, and then hyperosmolar hyperglycemic state or hyperosmolar non-ketoic coma. So those are the two entities that will come under the hyperglycemia. So last part we deal regarding the hypoglycemia. In this part we are going to deal regarding the hyperglycemia, mainly DKA. HHS will be in the next upcoming presentation. So before that, what is meant by hyperglycemia? So it is a simple term. There will be an excess amount of blood glucose level in the blood. Okay, there is a excess amount of glucose in the blood. So when the glucose level will exceed in our body. So normally in a normal healthy human individual, after having a food, there will be an excess amount of glucose. So there if you are checking after food half an hour or 1 hour, means you will get a hyperglycemia. But after some time what will happen, because of the healthy state, the insulin will come in the action and then they will do all our metabolism related thing, and then if excess glucose is there, means it will store in the muscles in the form of glycogen, adipose tissue everywhere. So lipid formation, everything will happen because of the insulin presence. But if the person have any problem related with an insulin, like if any problem in the insulin deficiency, means if there any problem in the insulin secretion, or if the person have a problem in the, there will be insulin, or there is a problem in the functional related one, insulin resistant, there will be a problem in the receptor, means at that stage that glucose level or sugar level will be in a stands in a higher range. Okay, first thing, healthy individual after having a food, the sugar level will be in a high state, and then insulin will come into the action, that will take over. But in the case of there will be a problematic insulin secretion, or there will be a problem in the insulin receptor, there the sugar level will stand in a higher state, that is a hyperglycemia. So by this concept only we are dividing into two group of diabetic mellitus, that is type 1 and then type 2. Type 1 mainly it is a insulin dependent, means there will be a beta cell destruction, because of that there won't be any enough insulin secretion. In type 2 diabetic mellitus, what will happen, there will be a problem, you have an insulin secretion, but there is a problem in the receptor, insulin receptor, that is called insulin resistance. So type 1 is called insulin dependent. Okay, type 2 is called insulin resistance. Okay, resistant to the insulin action. So some more types also we have, means some more hyperglycemia we have, like drug or chemical induced hyperglycemia, drugs like you are giving any corticosteroids, so those are the things, octreotide, so those are the things that will NSAID, so those are the things will increase the blood glucose level. Gestational diabetic, mainly that will occur in the case of or in the time of pregnancy in female. So those are the some subclassification of hyperglycemia. Type 1, type 2 is a major common one, and the gestational drug induced genetic defects also will come. So this is what the role of insulin we told, right? So what will happen actually, so you are loading the carbohydrate into your body, it will get into the stomach and then it will absorb and then it will reach out your blood vessel. So from blood vessel you have some transport channel like you have a insulin, so it will act like a transporter. So from blood vessel, that insulin will carry the glucose and then it will reach out your inside the cell. It will deliver to your mitochondria where the glucose metabolism will occur or aerobic metabolism will occur. So it will deliver here. So that is the one function of insulin. Okay, so it will transport the glucose from the intravascular to the intracellular. Okay, that is the one function. What is the second function of insulin means? So if your body have a too much means glucose that is more than the need. So if your body need only 50% of glucose, but you have a 70 or 80, 100% means that remaining surplus glucose, it will store as a form of glycogen. Okay, in the form of glycogen, it will store in the muscle or adipose tissue and then it will form some lipids. So those are the those are the things from the surplus glucose. That is also will carried over by the carry over by the insulin only. First function, it will transport the glucose from the intravascular to the intracellular. Second thing, it will store the surplus glucose as a form of glycogen in the muscle and then adipose tissue, that fat like lipid formation. Those are the things will carry out by the insulin. Those are the two major function of insulin. And then, so this is what the diabetic emergency we told, right? Two entity will create. First one is a hypoglycemia, second one is a hyperglycemia. Hypoglycemia, so definition wise it is a less than 60. So if it is going less than 40 means that is hypoglycemia crisis. If it is going more than 120 means you can call as a hyperglycemia. Again with some features we can define whether the person have a DKA or HHS, diabetic ketoacidosis or hyperglycemic hyperosmolar syndrome. And then we'll come to the scenario. So that is the idea regarding the hyperglycemia. Now come to the scenario. So either you are getting a direct call or from the dispatcher you are getting the call, like one bystander is calling reporting that the 52 years woman started talking irrelevantly about an hour ago and has a now suddenly she deteriorated and become unresponsive. So the key thing is, so you are in the pre-hospital somewhere else, someone is calling and then they are reporting that there is a 52 years old woman, she's 1 hour before she became deteriorated, means she have altermentation, now suddenly she gets collapsed. Okay, this is the scenario what you are getting in the from somewhere else. So here as a pre-hospital paramedic, before starting your transport or journey, what are the things, pre-preparatory things you have to keep in mind means, so you should have a wide idea, means you should have a what are the reason for the altermentation and then what are the reason for the sudden collapse. So you have to think about all the system, like if you are starting with the CNS mean, there you have to think about the like sepsis related things, septic encephalopathy or uremic encephalopathy, those are the things is there, right? So all the things you have to think about the CVA, seizure, and then might be a hypoxia or hypoglycemia. Hyperglycemia also you can think, DKHS also you can think, and then you have to think about the hypoxia related, any electrolyte related causes like hyponatremia. So those are the, you should have a wide range of idea regarding what are the reason for the altermentation. You should think again you should not have a narrow angle. So it might be a sometime it may be some other thing, but you will have idea, you will think, so it is mainly it is because of something or hypoxia only the person get deteriorates, like wait, you should not have a narrow window, you should have a wide window, right? Okay, then you arrive the scene. So once you arrive the scene, what we have to do, so before the transport you have to check the pre-preparation part. So based on that you have to prepare your vehicle, you have to revisit your vehicle whether all things are there, means what are the things you are suspecting, based on that whether you equipped your vehicle or not, that you have to check in a pre-preparatory part. Once you reach the site, ideally first step you have to check the scene size up. So in scene size up again you have to check the scene safety, your safety, and then your crew safety, personal protective equipment, additional resources, everything you have to check. Then what we have to check, so you here you verify the scene is safe for you, and then bystander is directs you to the patient, a 52 years old woman who is lying on the bed without any movement. So this is what the initial 10-second assessment or initial impression. So you are seeing the person, she is completely unresponsive state. So with in a non-medical term we given like a without any movement the person is lying on the bed. So ideally what we have to do, so once you found the person is like a stand in a still state, you have to go and check the response of the person. So by tapping and then shouting, and then you have to check the, if the person is not responding means, and then again as next step you have to do the pulse and then respiratory movement you have to check. Then if both things are there means, then you have to check the, immediately you have to check the glucose level, right? So hypoglycemia part itself we told. So it is a easily resolvable thing. More horrible if you are not treating the hypoglycemia immediately means, the person easily will land up in the more worst complication, like it can take the person up to the fatal level also. So easily treatable and then easily reversible condition. That is why immediately you have to check the glucose level. There if you by checking the glucose level, we found the person have a 430 milligram per deciliter. So that is the first we found the person have a hyperglycemia. Okay, so here you can exclude the cause of hypoglycemia. Now you have to think about the, in the context of hyperglycemia, what are the things, what might be what is the reason for the hypoglycemia, which induce hyperglycemia. So those are the things now you have to rule out. And then hyperglycemia in the sense, first then we started the initial assessment. So you found airway pattern and then there is no add-on sound. Breathing part, you see the person is breathing, but her breath are rapid and then deep breathing. So here that white this part you can see the waveform. So that is a Kussmaul's breathing pattern. You can see the rapid rate and then deep depth also, it is in a higher range. So this is called Kussmaul's respiration. SpO2 of 98% in room air, sees tachypneic respiratory rate of 32 breaths per minute. And then circulation part wise, she have a central pulse and then it is a rapid and then weak pulse. So the heart rate of or pulse rate of 104 beats per minute, you are checking the BP, that is 99 bar 60 millimeters mercury. So disability part wise, C is a response to the pain stimuli, that is again this is your AVPU. Okay, so she is not awake and alert, she is not responding to the voice, she is responding only with the pain stimulus. And then you are checking the GCS, that is showing E3, V4, M5, and then a pupillary assessment also is there. So exposure wise temperature of 98 degrees Celsius. So what are the challenges here we have by this scenario? First challenge we have, the person have a hyperglycemia. Second thing, the person have only response to the mental status I am talking. So the person is only response to the pain stimuli. So what are the things? The airway in a thread. So GCS also we have only 12. So you have to think about the airway thread. That is the second. Third one, the person have a tachypnea, mean the same time the person have a Kussmaul's breathing pattern. Okay. Fourth thing, the person have a hypotension, means mild hypotension and then tachycardia. So these are the challenges we have in front of us. So by this picture, you can provisionally diagnose the person have a DKA, hyperglycemia. In this hyperglycemia, the person have a DKA. How we are, by seeing this picture, how we are provisionally diagnosing DKA means, so there are some features are there like hyperglycemia and then Kussmaul's breathing pattern. Those are the things will give an idea regarding the DKA. So how we can without any without any advanced equipment or without doing any investigation, how we can provisionally diagnosis means. So let me give some idea regarding each thing, how it is happening means. Hyperglycemia means what is the reason for the hyperglycemia, and then let me tell regarding the Kussmaul's breathing pattern. So we'll take in for some explanation. By that again we'll come back to the scenario and then we'll see the management part. So we'll see diabetic ketoacidosis means there is a three entity or three partitions are there. Diabetic and then ketone and then acidosis. Means diabetic means what? It is a hyperglycemia. So if you are checking the blood glucose level, so there we send something around more than 400, right? So and then ketone. So if you are checking the blood investigation or if you take the urine sample means, there you can find the or there you can found the ketone bodies. Okay, ketone bodies trace will be there, and then you will have acidosis means you can the person will have a metabolic acidosis. So these are the three entities that will occur in the diabetic ketoacidosis. First one hyperglycemia, and then ketone, and then metabolic acidosis. Mainly it will occur in the type 1 diabetic mellitus, whereas your hyperglycemia that mainly will occur in the HHS that mainly will occur in the type 2 diabetic mellitus. So what is the pathophysiology happening behind the DKA means? So the same thing, here you have a cell, here you have a blood vessel. In blood vessel you have a like glucose content, right? Glucose here we have. So ideally what we told, insulin should be there, that insulin only taking care for the taking care of transport channel. But if you don't have a insulin means it won't transport any glucose inside the cell. Okay, there won't be any transportation between the intravascular to the intracellular because we don't have a messenger, or if we don't have a vehicle. Okay, that is the insulin deficiency. This is what the thing happening in the type 1. So we told mainly DKA will occur in the type 1 diabetic mellitus. The reason type 1 mainly it is a insulin dependent, means in type 1 diabetic mellitus there won't be enough insulin. So there won't be enough insulin means there is no transport. So your blood vessel have all means food, but your cell won't get that food, or your cell won't get that glucose. So what the cell will do, it will aid a help, or it will complain to your brain. So the brain, what it will do, so the brain will detect the problem. So the cell, like the brain will activate some other mechanism. So the brain directly will give a command to the like your compensatory mechanism, like it will secrete the cortisol, it will tell to your growth hormone, it will tell to your glucagon, thereby it will activate the compensatory mechanism. Again what will happen, because of the compensatory mechanism, again the glucose level will increase in your blood vessel. Okay, that is the reason for the hyperglycemia in DKA. Hyperglycemia. So you got a one reason. The second thing what will happen, because of this compensatory mechanism, that brain again it will do the something procedure called something called lipolysis, some unwanted or some unwanted metabolism like lipolysis, gluconeogenesis. Those are the some procedures those are the some process also will happen in your body. Because of this lipolysis you will get a ketone bodies. So the end product of lipid metabolism, you will get a end product of ketone bodies. So ketone bodies will form. One more thing, because of your gluconeogenesis, everything. So gluconeogenesis is nothing but your body will take glucose from the non-carbohydrate sources. So those are the thing, the term is indicating gluconeogenesis. Because of gluconeogenesis and then your lipolysis, your body again will develop some acidosis, means metabolic acidosis. Okay, so this is the reason for this is the reason why we are getting ketone bodies and then metabolic acidosis in DKA cases. So the first, the cell will complain to the brain because there is no glucose transport from the intravascular to the intracellular. Because of that complaint to the brain will activate the alternative pathway, or it will increase the counter regulatory hormone, thereby again there will be a load on glucose molecule, and then again because of that alternative pathway it will like lipolysis, gluconeogenesis, that ketone bodies and then metabolic acidosis will form. So this is what the three reason. And then again one more thing, because of this hyperglycemia it will increase, or it will create a osmotic diuresis, means there is a increased amount of solute in your blood vessel. Because of that increased solute, it will induce the osmotic diuretic, means osmotic diuretic means, so the body will lose large amount of fluids and then electrolytes from your body. So that is, those are the three entities. So first is a hyperglycemia, along with secondary to hyperglycemia you will develop the dehydration, the person will develop dehydration because of the osmotic diuretics. Not alone fluid, electrolytes also we will lose. Then second thing, you will get a ketone bodies. Third thing, you will get a like metabolic acidosis. So these are the three entities that will occur in the diabetic ketoacidosis. So in this three, you have to remember this hyperglycemia, ketone bodies, uh, uh, metabolic acidosis is a differentiating factor between the DKA and then HHS. Means in HHS you won't get the metabolic acidosis. That reason and all I will explain in the next presentation. But in DKA alone you will get the metabolic acidosis. So remember, if the person have a hyperglycemia ketone bodies, metabolic acidosis means straight away it point towards the diabetic ketoacidosis. But if there is a hyperglycemia, there is a we can't tell straight away there won't be any ketone bodies. There will be a mild trace we can found sometimes. Sometimes there won't be any ketone bodies. Sometimes you can trace some amount of ketones in your blood. So if you are finding means that is a case of HHS. Okay. So causes for the DKA. So what might be the reason? So again here also you can divide the people into two categories for simple understanding. First category people, those who are under insulin therapy, those who are not in insulin therapy. And then first, those who are under insulin therapy. Second category, those who are not in insulin therapy. Okay, those who are under insulin therapy, you can tell because of the inadequate insulin dose. So that is the one reason. Or there will be a skipping of insulin dose. So past 3 or 4 days or 1 week, the person may skip the insulin dose. Or there will be a reason for the some other condition called or state called non-compliant state. So those are the some three things that can can occur in the under insulin therapy peoples. And then those who are not in insulin therapy, there what will happen means because of any injury or emotional distress, and then there will be a pneumonia or UTI cases, like majorly infection. In infection you will get a UTI and pneumonia cases. There will be a excess amount of glucose secretion in your body. Sometimes these are the things that will suppress your beta cell of pancreas. Thereby you won't get any insulin. It leads to the ultimately it leads to the hyperglycemia. That is the way you can understand. First category, those who are under insulin therapy, and then second category, those who are not in insulin therapy. So these are the assessment point. In assessment point wise, what are the things you will get, like symptoms? So the symptoms mean there is a complaints or subjective data. So the person will tell he might have a polyuria, polytipsia, polyphagia, and then nausea, vomiting, leg cramps because of the, so your body will lose more amount of potassium, thereby it leads to the, because of hypokalemia the person will have a leg cramps, weakness, blurred vision. Abdominal pain is one of the most important differential diagnosis in a DKA. And then warm and then dry skin, dry mucous membrane, this is because of the dehydration. Signs wise you can find dehydration. So if you check the oral mucosa, if you check the monitor, there you can find the hypotension, tachycardia, and then cold extremities, peripheral cyanosis, air hunger. This is most important thing. So that is why I told Kussmaul's breathing pattern. So this Kussmaul breathing pattern, so with that only we diagnose the person have a DKA in a first initial or scenario, right? How we can tell means mainly we'll see what is meant by Kussmaul's breathing. So Kussmaul's breathing, right, means you know, right? So it is a rapid and then deep breathing pattern. So this is what the meaning of Kussmaul's breathing. When it will occur means in the case of metabolic acidosis only the Kussmaul's breathing will occur. Actually what will happen in metabolic acidosis, your pH will low and then your HCO3 mean HCO3 level or your bicarbonate level will get low. So ultimately indicating there is a excess amount of acid in your body. So in this state what your body will do, it will try to remove the excess amount of acid from your body. So that is the compensatory mechanism. So what is the compensatory mechanism? How it will remove means it the visible, only visible easily removable acid is your carbon dioxide. Means if the body removes carbon dioxide, there won't be any further formation of carbonic acid. So what the body will do, it will remove the carbon dioxide. So but how the body will remove? So you have to hyperventilate, then only the body easily can remove the carbon dioxide. Hyperventilation in the sense you have to do the take deep continuous tachypnea, then only the body easily can remove the carbon dioxide. So that is the reason here you are getting the deep and then rapid respiratory pattern. So that is called the Kussmaul's breathing. Only mainly we will get in the metabolic acidosis case. So if you are seeing any Kussmaul's breathing pattern, the person have a hyperglycemia means partially you can diagnose the person, provisionally you can diagnose the person have a DKA cases, okay, DKA. And then you will get a fruity odor of ketones, means fruity odor mainly because of the ketone bodies, there's some sweet smell, and then hypothermia, confusion, drowsiness, altermentation also can occur because of the hyperglycemia induced dehydration. And then diagnosis part, so those are the things will comes under the assessment in pre-hospital. In hospital, what are the diagnosis we can carry out means, you can see the elevated urea and then creatinine because of the dehydration, and then sodium level also you can check. You will see the every if sugar level in each every 200 mg per deciliter rise, that will reduce 1.6 milli equivalent of serum sodium level. And then serum osmolality level also you can check. Mainly it will helpful in the case of HHS osmolality level, and then blood glucose test also we can check. And then we have to rule out the cause for the DKA, which cause means which induced DKA. So what is the, we have to rule out the primary cause. So for that you can do the, we told right, infection, infarction, those are the causes. So you can work up for the infection, infarction, those are the things also you can do. So in ABG you can find the metabolic acidosis. Again coming back to the scenario, so hope you got the idea regarding why DKA occur, what are the three entities in DKA, and then we told regarding what are the assessment point, why the Kussmaul's breathing pattern is occurring. So by this you may get some idea, right? So regarding the DKA, and then now we'll enter into the how to treat or how to manage the DKA in the pre-hospital and in-hospital scenario. First, the same scenario. So again, we'll come to the point. So what are the, again, we told the challenges. First challenge, we have a hyperglycemia. Second challenge, the person have a less than 12 GCS and then he is only responding to the pain stimuli. So we have to, airway thread is there. So as of now, his airway is pattern, but we don't know when the patency will last. So you have to think about the airway thread, and then the person have a breathing rapid tachypnea is there. Sometimes if the tachypnea and the deep breathing pattern is continuous means, sometimes the person may get fatigue, respiratory muscle fatigue, and then it can land up into the respiratory compromise also can occur. And then circulation part, still the person have a mild hypotension, tachycardia also is there, and then remaining part exposure wise still now you have a mild hypothermia, either it can worsen the condition. So these are the some challenges we have, how we can manage. So first you start from the airway thread is there. So as soon as possible, if you want to go with a definitive airway, if the person have any respiratory compromise means, you can go with an definitive airway like endotracheal tube intubation, or you can go with a nasopharyngeal airway as of now, or you can go with an oropharyngeal airway. But the oropharyngeal airway you have to should consider whether the person have an intact gag reflex or not. If the gag reflex is not there, and then you can go with an oropharyngeal airway. Okay. So what the management part in a DKA wise, what are the things you have to keep in mind means, again I will write the triad: hyperglycemia, and then secondary to hyperglycemia you will have a dehydration plus electrolyte imbalance. Second thing, you will have like a ketone bodies. Third thing, you have a metabolic acidosis. So the first primary management in the DKA, you have to replace the lost volume. So you have to address the dehydration. That is the first foremost step what we have to do in the pre-hospital, both pre-hospital and then in-hospital. So first you have to address the dehydration. How we can address the dehydration? So you have to, in DKA, there is approximately the person will lose 6 liter of fluid. Okay, 6 liter of fluid the person will lose in the case of DKA approximately. So you have to replace that 6 liter, and then you have to keep the person in the maintenance fluid also for further until the hyperglycemia resolves. So how we have to give means, for the initial time you have to give a 1 liter of fluid in an hour. So for half an hour or within a half an hour to 1 hour, we have to give the 1 liter of fluid, and then we have to follow that 1 liter for further 2 or 3 or 4 hours. Okay, likewise you have to manage your plan. The ideal fluid of choice means you can go with a 0.9%, that normal saline you can go with. If the sugar level is less than 200 means, then you can shift your fluid from the 0.9% to the 5% dextrose. So that is the fluid. Both two fluid of choices we have. First one, ideally you have to start up with the normal saline, that is a 0.9% normal saline. Once after, so you have to aim for the half liter, sorry, 1 liter for first half an hour to 1 hour, and then subsequent hours you have to target the 1 liter for the 2 or 3 or 4 hours. Either you can fix it for 2 to 3 years you have to fix. Then after that, if the blood glucose level less than 200 mg per deciliter means you have to shift the fluid from the, instead of normal saline you can go with an 5% dextrose. Okay, so that this is regarding the fluid management. Again, fluid management, you have to what are the challenges in the fluid management? Management means those who have a cardiac failure or renal failure cases, there is a chance of fluid overload. So in pre-hospital, how we can assess the fluid overload means, so initially it will like react in the form of pulmonary edema. So if you auscultate over the pulmonary region, if you are finding any crackles over that region means, though partially you can confirm the person have a pulmonary edema because of that fluid overload. But if you are in a in-hospital means there we have a lot of modalities, like you can go with an USG, or you can check the jugular venous, like jugular venous pressure, inferior vena cava. So those are the some modalities what we have in the definitive care in-hospital. But pre-hospital, frequently you have to auscultate the lung region. There you can see the any crepitation is there means ultimately that is indicating the pulmonary edema because of the fluid overload. So this is regarding the fluid resuscitation. And then second part we told we have to treat the what we have to treat. So hyper dehydration we have to address, and then second you have to address the electrolyte imbalance. Mainly electrolyte, you lost the sodium. Anyway, sodium we are giving in the form of 0.9%, so that will correct. Second thing, the major important electrolyte is a potassium. Either both side, hypo or hyperkalemia, both are danger sides. So both will cause the myocardial instability and then arrhythmias, lot of things. So you have to correct the potassium as soon as possible. So in a pre-hospital, it is not possible because we won't get a value how much it is. But in hospital, we will get a ABG, or through initially you will get through ABG, or you will send a sample, thereby you will get a laboratory value of potassium. Based on that, we have to correct the potassium level. So ideally, you have to keep the range above 4.5 you have to keep in the case of DKA. So normal it is about 3.5 to 5, but here you have to target about the more than 4. And then third one, so that is regarding the fluid management, hyperglycemia. So and then second thing, you have to treat the case of hyperglycemia. How we can treat the hyperglycemia means, here you have to start up with the exogenous, your insulin infusion. So the way we are giving the insulin is a infusion manner. How you can prepare the insulin infusion means, in our institution we are giving like a 40 units in 40 ml, means that we'll call as a 40 by 40. Okay, 40 units in 40 ml. So each unit contains, each ml contains 1 unit. So 40 units, how we will prepare means, we will take 1 ml of human atrapid in 39 ml of normal saline. Okay, 1 unit in the sense that 1 unit means that is a 40 units of human atrapid, right? So 1 unit will take, and then we will take remaining 39 ml of NS. So totally it will come 40 ml in 40 units, 40 units in 40 ml. So each ml contains 1 unit. So this is the way we will prepare the insulin infusion. So the how here in our institution, how we have to start the this dose and then infusion rate and all. Here we have a something called Delta protocol. Based on that protocol, we will start and then we will continue the infusion. But each one have a separate protocol. So you can follow your institution format. Initially, we have to start with the 0.15 units per kg. So that is the initial dose which we have to start. And then if you don't have any protocol like that means, simply you just divide the glucose level divided by 100. There you will get a like how much insulin infusion you have to continue, you will get a ratio. Means if you have a glucose level of 500, so you just divide by 100. there you will get, here we will get a 5 units. So you have to continue with the 5 units. Again after 2 hours, or in our institution every hour we will check and then we will change the infusion. Some other institution they are following for the 2 hours. So every 2 hours they will check the glucose level and then they will change the infusion rate. Here the same thing only, every hour or every 2 hour you have to check, and then again you have to divide it by the 100. Based on that you will get a one value. By that value you can go for the infusion. So this is what the in hyperglycemia management. So and then remaining 3 things, like we told only hyperglycemia and then dehydration management. Second thing, ketone bodies, there is no specific treatment, or you don't want to treat the ketone bodies. Automatically if you are giving fluid and then you are treating, you are giving hyperglycemia management, automatically your ketone bodies will disappear. And then one more thing, metabolic acidosis also, there is if you are getting more severe metabolic acidosis, like if it is going pH of less than 7.1, HCO3 level of less than 15 means, there you can address with the soda bicarbonate, or else you can treat mainly this dehydration and then hyperglycemia. So remember, first you have to treat the dehydration with the fluid therapy, and then as well as you have to consider about the electrolyte imbalance, sodium, potassium, and then calcium, magnesium, phosphorus, everything you have to address. Second thing, you have to ideally treat with an your like hyperglycemia management, that we are following the insulin infusion protocol. Third thing, regarding the supportive measures. So what are the supportive measures? You have to strictly monitor the input output, and then you have to check the nasogastric tube, and then if the person is unconscious you have to go with the nasogastric tube, and then central venous access, so to monitor the fluid overload, and then central venous pressure, and then antibiotics. So if antibiotic needed means, prophylactic antibiotic needed means, you have to go with the prophylactic antibiotics. Magnesium and phosphate correction also should be there. So remember, here only we told regarding the DKA management. Primarily you have to address the cause for the DKA, means which causing the DKA. So primary cause you have to find. If it is a MI, you have to treat the MI. If it is a UTI, urinary tract infection, means specific antibiotic should be done. So those are the management strategy for the DKA. So this is the way you have to remember. So first after your correction everything means, ultimately 3 to 5 days the DKA will resolve. First sign the decay resolving, what it will be means, so first the ketone bodies will disappear from blood and then urine, and then second thing, your metabolic acidosis will get corrected, then your glucose level will be in a controllable manner. So this is the sequence. First ketone bodies will disappear, then metabolic acidosis will comes in the control, or else at final your hyperglycemia will come, the glucose level will come in the normal level. So this is the way the DKA will gets better, or DKA will disappear. So this is the whole thing regarding the DKA management. So do your best. Shalom.